Hello everyone and welcome back to Causality with Boris, all broadcast from Sobolev Spaces. In this video I talk in detail about averaging the stratum-specific effects. You will learn about similarity between averaging in stratification and pooling effects in meta-analysis. Two main topics in today's lesson: effect heterogeneity and effect modification. Make sure you watch till the end and compare the takeaways with your notes. As always, I've prepared a material that goes along with this video. Check out the link in the description and the PDF will be sent to your inbox. Here is the core idea of stratification. We compare outcomes of treated and untreated units in each stratum. Within a stratum, the values of stratification variables are fixed, and the reason they cannot influence treatment allocation and outcome within a stratum. We find the mean outcome in each treatment group across strata, then calculate their difference. We believe that's the true stratum-specific treatment effect. Two different goals motivate stratification. One is to block the influence of factors other than treatment. The other is to explore the effect modification. Effect modification refers to a change in the magnitude of an effect according to the value of some third variable. Third if you count treatment and outcome. And sometimes it's the effect direction. Effect modification is a natural phenomenon. Conceptually, it's similar to variation in individual treatment effect. Recall, it's a difference in the state of exchangeable units after applying and withholding a treatment. How do we summarize individual treatment effects? By averaging them over individual units. We summarize variation in stratum-specific effects in similar way, by averaging them over strata. The average treatment effect is a sum of the stratum-specific effects, after they weighted by the proportion of observation in respective strata. I prepared this table to illustrate the idea. It presents stratification by the combination of values of three binary variables. That is, they can be either 0 or 1. In this case, combinations of their values define 8 strata. Each has its own proportion of units relative to the study population. We denote it as P of stratum number from 1 to 8. Stratification is a means for achieving group comparability, and within each stratum, treatment groups are comparable, because stratification variables have the same values, and because conditioning on them blocks all other influences. Then, we reason that the treatment effect is not mixed with other effects, and its size is unbiased. We conclude that the average of stratum-specific effects is unbiased as well. Let's take a look at example of timing of heart surgery and postoperative mortality. In patients with stable heart disease, surgery is done to reduce chest pain and to increase longevity. But surgery on the open heart is a major intervention to human body, and it runs its own risk of postoperative death. This table shows hypothetical data from a cardiac registry. The columns refer to the timing of surgery. It's a time between the decision to operate and the operation itself. Surgery is delayed if this time exceeds a clinically appropriate period. Otherwise, it's labeled as early surgery. So we compare mortality between two study groups, early and delayed surgery. Now let's take a look at these rows. There are age groups of patients undergoing the operation. Age is a major risk factor for postoperative mortality. It also may influence the timing of surgery. Stratifying on age allows us to remove age from mixing with the effect of timing. We examine mortality between timing groups for every age separately. Table's entries are counts and proportions across the age strata. The uppercase N is surgery counts, the lowercase n is the counts of death. Table shows two types of proportions: proportions of surgery with recorded postoperative death and strata proportions. Proportion of deaths are the age-specific outcome probabilities, the risks. Even though heart surgery is a safe procedure this day, still postoperative mortality could reach several percent. Strata proportions represent surgeries in age group relative to all surgeries in the table. For example, let's look at the patients 80 and older. They have 400 surgeries. Their proportion to the total patient population is about 4%. Now look at the second last column. That's the effect of delay in surgery in each age stratum. The overall risk difference is computed as the average of these age-specific differences. That is, we take the effect from each stratum and multiply it by the proportion of patients in that stratum. The result is mortality effect of surgery timing. If everyone had surgery within a clinically appropriate time, then 2 deaths in every 1,000 surgeries would be avoided. There is another way to get the same results. We can average the age-specific risks in each timing group, then take the difference between the averages. For this, we need only 4 types of aggregate data. First, capital N is the total number of observations in the study population. Second, small case n with 2 subscripts S and G, it's the number of observations in strata S in group G. Third, small case n sub s, it's the number of observations in stratum S. And fourth, small case n sub s and G and superscript 1, it's the number of outcomes in stratum S and group G. So how do we get the marginal risk? We take the proportion of outcomes in study groups and the stratum proportion in the study population. We multiply these 2 proportions in each stratum and then sum them up over all strata. But let's go beyond age-defined strata. Suppose there are combinations of conditioning variables, and they define a series of disjoint strata. We estimate the difference in the expected outcome between treatment groups, and that's done within each stratum. What's the overall treatment effect? It's an average of the differences we find in strata, and it's weighted by the distribution of strata in the study population. This graph shows an example of 2 strata. One is blue and the other is purple. The color shade represents treatment groups. Lighter shades are the control group. Boxes denote the outcome occurrence. We estimate the outcome probability in treatment groups for each stratum separately. Look at the blue stratum in this hypothetical example. It's 1 and 2 in the control group and 1 and 4 in the treatment group. And for the purple stratum, it's 4 and 7 in the control group and 2 and 7 in the treatment group. In each stratum, we apply the strata proportion to the outcome risk in treatment group. What does it really mean? It means that we consider 2 counterfactual situations. Mortality that the control group would have experienced had they been treated, and the mortality that the treated would have experienced had they been in the control group. Effect modification refers to variation in stratum-specific effects. If we have strata, then we're likely to see variation in effect size across them. In our example, the effect of delay is harmful for some groups, it's neither harmful or beneficial for some other groups, and it's potentially beneficial for others. Here's the first step in exploring effect modification. Inspect the stratum-specific estimates of the treatment effect. And the second step is the interpretation of differences across strata. Variation could be purely random, or it could indicate the effect heterogeneity. Sometimes subject matter knowledge can explain the pattern of the variation. Typically, however, biological insights are limited in health research. In many cases, we resort to statistical tests. In clinical epidemiology, averaging of strata-specific effects is conceptualized as a meta-analysis. This graph is a typical display of meta-analysis. It shows age groups and their respective effects. A risk difference is the effect measured here. See the black square with whiskers? It's a point estimate with standard error. The diamond is the overall effect. They say the strata effects are pooled to estimate an overall effect. There are various formulas for pooling strata effects, and they are broadly divided by assumptions. And this is about the source of variability: random variation due to sampling or the effect heterogeneity. The random effects model is a simple choice for pooling the heterogeneous effect, because it doesn't assume the same effect size across strata. It's simply the best average of the sample means. There is an old argument that presenting only pooled effect is insufficient if the stratum-specific estimates vary significantly. Some point that the pooled effect is a weighted average, therefore it's dependent on the number of observations in individual strata. In my view, this argument conflates two perspectives: causal meaning of stratification and statistical estimates. So here's the main message. We consider two counterfactual situations when apply strata proportions to risks in treatment groups. One is mortality that control group would have experienced had they been treated, and the other is mortality that the treated group would have experienced had they been in control group. You learned about the effect heterogeneity and effect modification associated with stratification. You learned about similarity between a pooling strata effect in meta-analysis and averaging in stratification. I will expand on this idea in the next video. Keep on watching.